And that's a great segue to follicular lymphoma, where I think there is potentially a chance for going chemo-free going forward. So Loretta, do you want to take us through the treatment landscape of follicular lymphoma?
Yeah, the problem with follicular lymphoma is it's such a heterogeneous disease, and how we approach it is equally heterogeneous, meaning you could get 5 different opinions and they could all be different and they could all be wrong, right? So I think we apply sort of our clinical lens to patients, so how much disease they have, what are their comorbid conditions, how important is it to them and us to eradicate the disease or minimize how much the disease is present. It's a very different approach. And so as a result, if you look at NCCN, you'll have 5 to 6 options for front line, 7 to 8 for second line, and even more as you get into later lines. And so we don't have good ways to risk stratify follicular lymphoma. They generally live a very long time. And so you're balancing more the toxicity of the treatment with our ability to reduce the amount of disease. And there's a quality of life factor that I think we don't always capture well in our prospective studies. But patients don't want to travel, they don't want to be in a hospital setting, and they don't want to have toxicity that's going to linger. And so that's generally the driving principles in follicular lymphoma. But currently, most are getting chemoimmunotherapy in frontline, a lot of which is bendamustine-based because of the toxicity profile. At relapse, depends on where they are. Many are still getting chemoimmunotherapy at second line. Some are getting a lenalidomide-based approach. We've got some exciting data coming out here that adding a bispecific into R-squared looks to be an effective strategy. We knew last year that adding tafasitamab into R-squared was an attractive option. So we're just going to get more and more sort of triplets moving into that second line space. And then that third line space is where you see the bispecifics and the CAR T come in. And so I think I'm clearly a big fan of CAR T. It's a harder sell sometimes in follicular lymphoma, but we're seeing some 3-year, 5-year, 6-year updates that it looks to be quite effective for high-risk patients. And so I think there are a lot of options. Most of your providers are going to tailor it to the patient's needs and where they live. And so it makes it actually a little bit harder as we get more treatments in that space.